We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. A 40-year-old female patient presents with palpitations and difficulty in breathing. Auscultation reveals a mid-diastolic murmur and JVP shows a prominent A wave. What is the most likely diagnosis? Your options are. And the correct answer is tricuspid stenosis. Here's the explanation.
On physical examination, one of the very standard features that you will always notice will be presence of large A waves in the patient, which is explained by the fact that the right atria is having to work against pressure. I have spoken about this even in my discussion of JVP and heart sounds, but I'll just draw a line diagram to highlight this again. One, I am showing in this particular diagram that because tricuspid stenosis is present, so therefore there would be increased pressure in the right atria. This pressure will contribute to the right atria having to generate more force to push blood in a forward direction, which will cause this jugular venous column to go up higher than normal, and that explains the large A wave. At this junction, I want to say that there is a possibility that in the exam, he might actually ask you about isolated tricuspid stenosis also. Then the question will not talk about features which I highlighted in, I would say, rather bold initially. These are features which will be written if the two are coexisting. But if in a question he decides to ask isolated tricuspid stenosis present in a patient, I agree it's there, but if it is present, then these features will not be present. It will be mainly features of right-sided congestion that will be manifesting in the form of what I've explained, the pedal edema component, the ascites component, and even hepatomegaly or abdominal fullness. Another problem that you will be able to identify, especially with respect to the JVP, will be related to the Y wave. Now you very well know Y wave is related to relaxation of the heart. So I'm going to just draw this line diagram once again before you to say that because there is a narrowing present, so therefore because of this substantial amount of narrowing, the amount of blood that is able to enter, imagine this is the stage when there is a rapid ventricular filling occurring, the amount of blood that will be able to navigate across this will be relatively lesser, and at the same time because this is acting like an obstruction, so therefore the Y descent in this patient will appear blunted. What I have done symbolically here is that instead of showing a traditional Y descent the way it should be, I have tried to symbolically represent with a smaller red arrow that Y would be blunted, and that's again important from the exam perspective because we are used to reading about steep Y descent. I have discussed situations where we get a steep Y descent, but this is one of the first times that I'm highlighting the term blunted Y descent. So the statement that I'm writing on the slide at the moment, I would suggest that to be remembered as one of the important pickup points in the MCQ, because in any clinical question, the stem of the question will have some pointers present. So the message at the moment learned is if the two are coexistent, it will be still easier for you to pick up because he's going to give that classical history of balloon valvotomy being done. But if he's going to talk about isolated tricuspid stenosis, then the main pickup point would be large A wave with a blunted Y descent. Another feature that can be especially very useful for identifying this condition is pulsations in the liver. Now the point is the pulsations of the liver, are they systolic or are they diastolic? Let's have some logic into it. Tricuspid stenosis operates in diastole because you see tricuspid valve is for filling of blood in the heart. So during diastole, when the blood is trying to come into the right side of the heart, there is a physical obstruction. So therefore you will be always reading this term pre-systolic pulsations of the liver, and as you will progress in this discussion later, you will notice me saying systolic pulsations of the liver. You see, one word is changing the entire domain. If I say systolic pulsations of the liver, it means right ventricle blood is going back to the right atria and therefore is causing pulsations in the liver. And when would RV blood go back into RA? Tricuspid regurgitation. So if you read systolic pulsations of the liver, it's going to be tricuspid regurgitation. But if you read the word pre-systolic pulsations of the liver, the reading of words is of paramount importance fast in the MCQ, because ultimately you get about 1 minute approximately to solve a question. In that you have to read the entire clinical stem and read the options and exclude the 3 options and get to the right answer as well. So it's the word pre-systolic pulsations of the liver which is to be remembered. I would like to say that if he is not gonna be specific and if he is gonna not at this moment want you to make a diagnosis, he will just say the word pulsatile liver. Though pulsatile liver is also described in the earlier part of the app with respect to aortic regurgitation, just now I have taught you it can be seen with tricuspid stenosis and tricuspid regurgitation. Technical inputs are provided with respect to tricuspid stenosis because it operates in diastole, it's going to be presystolic. TR operates in systole, so it's going to be systolic pulsations of the liver. And now I'll be focusing on the murmur. Just like mitral stenosis contributes to a mid-diastolic murmur, a tricuspid stenosis will also contribute to a mid-diastolic murmur in a patient. Now I have to differentiate whether it's going to be a murmur, mid-diastolic one originating from left side of the heart or the right side of the heart. So you very well know that you will be asking the patient to take a deep breath, because on inspiration, because blood is sucked towards the heart, all right-sided heart events tend to become louder. I repeat my statement. On inspiration, when you ask the patient to breathe in hard, the blood will be sucked towards the heart, more blood will increase the turbulence. So all right-sided events tend to become louder on inspiration, and that is what I have highlighted here before you. In mid-diastolic murmur or mitral stenosis, you will not have a increase in the intensity of the murmur, but in tricuspid stenosis, the murmur intensity will definitely increase. You will be able to hear this murmur on the left lower sternal border. That would be tricuspid area, primarily I would say very close to the tricuspid area. And the main message is that tricuspid stenosis can exist isolated also. I mean, there was a situation in NEET PG 2021 where they gave a isolated tricuspid stenosis, which was mainly related to large A-wave blunted wide descent and features of isolated right-sided involvement like pedal edema, etc. given in the question. There was no pulmonary edema explained. So I want to make it very clear before you that do not expect that every question is going to talk about only a rheumatic. I agree, in India, rheumatic heart disease is common. So that's our thought process as an Indian doctor, but then they expect us to realize the fact that if it's going to be isolated, then the standard features that I've written on the slide and I've highlighted a couple of times are not present.
Question 2. A 65-year-old patient presents with tremors, rigidity, and bradykinesia. Pathological examination shows the presence of Lewy bodies within the neurons. What is the most probable diagnosis? Your options are, and the correct answer is Parkinson's disease. Here's the explanation.
Braque staging for the progression of Lewy body pathology. Now, this is an update from the 21st edition of Harrison, and he has described this. In fact, I would not say that he's saying something new, but the way he has said it is slightly different from what was given in the older editions. You see, earlier we always used to study that non-motor manifestations would be preceding motor manifestations. Obviously, the motor manifestations in Parkinson's disease or Parkinsonism usually start about 60 years of age. In fact, Parkinsonism, guys, is a generic term, and one of the leading causes of Parkinsonism is PD, that is Parkinson disease. Parkinson disease can be having a sporadic onset, it can be having genetic reasons behind it. So I'll be describing the genes also responsible for PD, or it could be sporadic as well. But the point at the moment is, how is the disease evolving, or what are the manifestations? So first we get non-motor manifestations, and when I say non-motor manifestations, constipation and anosmia are one of the early manifestations that we see. Now, I've said that in the previous edition as well, but this time just changing the way that I am presenting it. The way he's giving it in the book currently, he says that the earliest involvement in Parkinsonism patients would be with respect to the peripheral enteric system. You see, if the peripheral enteric system is involved in these patients with the Lewy bodies, manifestations are obviously what he's talking about, that is constipation, and then the disease is gonna spread via the peripheral enteric system using the vagus nerve. So subsequently, even the anterior olfactory nucleus would get involved, and the involvement of this will explain the development of anosmia. So the data is still the same, that non-motor manifestations would be preceding the motor manifestations. Most of the time in like the 4th and the 5th decade of life, these patients will be having mainly these non-motor manifestations, and the motor ones would be subsequently manifesting. And well, how would it spread across to the brain? Then you're aware from anatomy that the cranial nerve, which is having the longest course overall, I mean, in the brain per se, we have obviously the trochlear nerve that is longest, but overall the longest cranial nerve is the vagus nerve. So via the GI, it would move up by the vagus nerve towards the brain, which also explains why the dorsal motor nucleus of the vagus is also involved in this condition. And once the dorsal motor nucleus of the vagus gets involved, or the vagus per se gets involved. Therefore, we can understand the cardiac denervation that will be occurring in this patient. In fact, one of the important diagnostic criteria for diagnosis of Parkinsonism nowadays is to demonstrate this cardiac denervation with help of a FTG PET. In fact, that looks very surprising because traditionally, whenever we are discussing a CNS condition, we are thinking that it would be like a MRI or a CT finding that would be diagnostic. But look at what I'm saying, sounds very, very peculiar. Cardiac denervation is one of the important features that tells us that yes, it is Parkinsonism, and we can differentiate it from a secondary Parkinsonism or atypical variety of Parkinsonism as well. So cardiac denervation implies that orthostatic hypotension or autonomic manifestations would be developing in these patients as well. Now, motor manifestations would occur at point number 4 when substantia nigra and the alphabet C, though I've said it, but I'll just jot it down at the moment. Substantia nigra, pars compacta is the one which would subsequently get involved. I mean, we have pars reticularis, pars compacta. On a comparison basis, if both are getting mentioned in the MCQ and you have to select one with respect to the hallmark pathological manifestation which causes motor manifestations, because now motor manifestations will start occurring, is going to be substantia nigra, pars compacta. And what are going to be the motor manifestations? Well, they're going to be in the form of bradykinesia along with tremors and rigidity. In fact, these are like 3 important features of this condition. Though obviously the tremors here will have peculiar manifestations, like they're going to be asymmetrical, then there's going to be pill rolling tremor, but the must-have criteria without which the diagnosis of Parkinsonism cannot be made is bradykinesia. So that is itself an MCQ, and that is the term I started this video with, that what's a must-have criteria for diagnosis of this condition. Repetition once again to facilitate your remembering, that's going to be bradykinesia. Now, after substantia nigra compacta, we'll also be having involvement of the cerebral hemispheres, and this will explain why do you get cognition defect in these patients. So even cerebral hemispheres are involved. I mean, traditionally we read about cerebral hemispheres, I mean the cortex getting involved with respect to Alzheimer's disease. But what I'm trying to say is that we will be having some level of cognition defect even with respect to Lewy body pathology, which is going to progress in this particular fashion, and it is at point number 4 that the motor manifestations would be developing at around about 60 years of age. In fact, here I can also show you a snapshot because there's going to be a very peculiar manifestation. It's not a very diagnostic feature like bradykinesia or tremors or rigidity, but yeah, worth mentioning because there would be a change in the handwriting of these patients. You see, if I'm going to write fast, the alphabet that I'm writing will almost be of equal size. Our basal ganglia are going to help in coordination. Basal ganglia will ensure that we do wanted movements and filter off the unwanted movements. And whenever we are writing, the alphabets are almost of the equal size. But in case there's a basal ganglia malfunction, well, the handwriting gets affected. Patients of Parkinsonism, that's how they used to teach us traditionally, would be an elderly gentleman whose checks in the bank are bouncing because his signature is becoming difficult to read or his handwriting is becoming slower. In fact, if you compare his handwriting initially versus the handwriting that you can see at the moment, it is almost illegible. The handwriting will become very slow. I'm not saying that this is a diagnostic criteria, guys, because see, a lot of people in India would never be knowing how to write because of the illiteracy component. Or there's a possibility that patient might be having a tremor on the hand in which he would not be using for writing. So overall, I can say that because there are asymmetrical manifestations in the disease, so there is a possibility that the writing hand of the patient may not be affected. But still, overall, I can say that this is a very peculiar manifestation in the era of UPI and Paytm. I mean, nobody would be signing a check anymore. But that is how traditionally, when we were in medical school, we were introduced to this disease, that there's an elderly gentleman. He has to withdraw his check. Every time they get a pension, they'll have to withdraw money from a bank. Now, no, we don't do that anymore, right? Nobody goes to a bank anymore. But in earlier times, people had to go to a bank, stand in a queue, get their pension withdrawn. And that's when the banker used to refuse their checks because they might have opened their account when they were young, but now their signature is not matching. So that's the manifestation that we see with this disease. So micrographia is not a very important diagnostic feature, but just a fact from history that I just wanted to share with you.
Question 3. A 45-year-old HIV-positive male complained of persistent cough, weight loss, and neck stiffness. He has skin lesions that appear as umbilicated papules and nodules predominantly on the face, trunk, and upper extremities. Physical examination also reveals neck rigidity. Chest X-ray showed multiple bilateral nodular infiltrates. His sputum CB-NART for tuberculosis was negative, and he has a CD4 count of 20. What is the probable diagnosis? Your options are, and the correct answer is HIV with disseminated cryptococcosis. Here's the explanation.
Cryptococcus neoformans, or for that matter of fact, Cryptococcus gattai, are the organisms which are incriminated, especially when the CD4 count in a AIDS positive patient will be reduced. Nowadays, because of the advent of the combination antiretroviral therapy, the opportunistic infections found in AIDS positive patients have dramatically reduced. But in earlier times, in the paucity of combination antiretroviral therapy, the CD4 counts were dramatically low, and especially values less than 100 per microliter will increase the incidence of this infection, which will contribute to development of subacute meningitis or meningoencephalitis in a patient. So when you are gonna be reading question related to Cryptococcus neoformans, don't be under impression that it's always gonna be history of few days. Sometimes the illness can span over a couple of days as well. And when I describe the case, it will become relatively more easier for you. They have also incriminated or asked a microbiology detail in the exam related to Cryptococcus neoformans, that they have said that how does it actually reach the patient. You see, obviously the organism will enter in the body of the patient via the lungs, but then how did the person inhale it? So you would be aware from the microbiology domain that this organism per se is excreted in the pigeon droppings, and inhalation of this can happen in you and me also, but because we have is a good immunity, so therefore this organism will be killed and the infection will be terminated. But in a person with a low immunity, the predisposition would be that the infection will spread from here into the blood and then cross the blood-brain barrier and reach the brain of the patient. So most of the questions that will come on this topic will begin in this fashion. He will describe a 30-year-old AIDS positive truck driver. You are anyway aware that in our country, per se for the truck drivers have been responsible for spreading the infection far and wide to almost each and every state. Now, this AIDS positive truck driver has not been feeling well for past couple of days, so he maybe went to a chemist and did not go to a doctor and was taking paracetamol off and on. Along with this, there was a component of headache also. So he will definitely try to tell you regarding the CNS manifestations, and will say that this truck driver could not drive the truck last night. You would have seen the truckers when they do shifts, they might be driving the truck for the day as well as for the night. But this guy was having severe photophobia. So especially with the oncoming traffic and the headlights at full blaze, there's a possibility that he was not feeling well and he did not drive the truck. So because of the fact that there's gonna be an occupational problem for this guy, like he's not gonna be able to deliver the consignment on time, this guy was worried and decided to see a qualified doctor. The history might be spanning over a couple of days to couple of weeks, and on physical examination in this guy, you noticed evidence of meningeal irritation. The findings that were given were like nuchal rigidity, then Brudzinski sign, Kernick sign. All the standard features would be tested by the doctor so that we are sure that we are dealing with a case of meningitis. Now here I definitely want to highlight that he may not actually straight away mention about the meningeal signs in a patient, but he might just mention that the reflexes of this patient is relatively brisk, or he has noted an extensor plantar because ultimately meningoencephalitis is occurring. So if there's an encephalitis component coming up, then there's a distinct possibility that the reflexes might also be relatively faster. And I need to do a quick workup of this guy so that I can come to the conclusion that the organism incremented is Cryptococcus.
Question 4. A patient came to the medical OPD with complaints of polyuria. He has a history of undergoing total hypophysectomy. His sodium levels were found to be 155 milliequivalents per liter. Urine osmolarity was 200 milliosmoles per liter. What is the definitive management in this patient? Your options are, and the correct answer is DDAVP supplementation for lifelong. Here's the explanation.
a collection of the urine specimen, and we usually try to do it over 2 or 3 days. Because why I'm saying that is because when you ask a patient to collect urine samples, especially in government settings, you may not be having proper containers to measure the exact amount of urine, and patient might under collect or the patient might over collect also. So I said just to ensure that the patient is familiar with the procedure, I do a couple of dry runs, and then once the patient has understood what I really want is the exact timing 24-hour urine sample. So this will definitely demonstrate the polyuria component, which I've defined is more than 3 liters, but there is no evidence of dehydration. Now we will need to check the urine osmolarity and the plasma osmolarity simultaneously. At that particular point of time, when you collected the urine specimen, you will check the plasma osmolarity also. The basic concept is in diabetes insipidus, after all, there's going to be loss of water from the body. So loss of water will contribute to dilute urine, and therefore I put an arrow going downwards, urine osmolarity will be reduced. Remember my next statement that will help you in MCQs and will make your life easier. Urine osmolarity and plasma osmolarity have a opposite direction, or they have a inverse relation whenever you gonna be having antidiuretic hormone coming in the picture. Just like I was saying, sodium potassium have an inverse relation when aldosterone comes in the picture. Now you have learned whenever there's gonna be vasopressin coming in the picture or antidiuretic hormone, urinal plasma osmolarity will go the other way around. Or you can just work it out logically also. If you lose water from the body, the word is loss of water from the body, then the plasma will become concentrated. So plasma osmolarity will be increased. And at the same time, if I check out the sodium values in the body of this person, you see, after all, there is loss of water, there is a dilute urine being passed. So therefore, if you lose water from the body, then if I focus on the sodium concentration, it will be increased, and he might write the word relative hypernatremia. Along with this, I also need to check out the plasma antidiuretic hormone values, which I've explained will be either elevated in the nephrogenic variety or can be even reduced in the central variety, but polyuria will be a common finding in all of them. But they would definitely love to ask you about the classical name, that is one of the important tests for this condition, that is Miller-Moses test, or we casually call it the water deprivation test. So what I'll describe next before you is that how this test would be done, though in the exam it is unlikely that he will ever ask you regarding interpretation of a water deprivation test. I mean, he can ask that in a super specialty exam, but it is highly unlikely. But let's have a look at what this test will do to a normal person, so that we are at least able to understand how the disease diagnosis will be made. You see, all you're gonna do in this patient is do a water deprivation. Now, how much water deprivation? That's important. So in the textbook, they will describe that you will have to do water deprivation till you get at least 2 dilute urine samples. I'm putting it simple. You see, what you can do is we will do water deprivation, strict one in the patient, till there is at least 3% decline in the weight of the individual. So just like you're aware, no, these wrestlers or these bodybuilders or people in mixed martial arts, before they compete in a particular competition, they have to definitely come down to a particular weight. Like if you are a wrestler, you can participate in a 48 kilogram category or maybe a 55 kilogram category. So these wrestlers, they stop drinking water at all before they actually go in for a weigh-in, and then they subsequently are able to participate in the competition. So a similar kind of strict water deprivation would have done, which has resulted in approximately 3% decrease in the weight of a healthy individual. Now, if you are not gonna drink water for a very, very long time to the level that your weight is decreasing, then your urine will become highly concentrated. So I'm just putting arrows here to say that urine osmolarity will almost become 4 times of the plasma osmolarity. This is what we have determined in settings, that if you deprive a healthy individual, let me say a wrestler, boxer, whatever, to the level that is losing weight, then urine will become highly concentrated, up to 4 times of the plasma osmolarity. 2 to 4x here means plasma osmolarity. So let me just put numbers here. Let me say plasma osmolarity is 280. So I'll just multiply this by 4. So I can say that the approximate values would be around about 1100 milliosmoles. You see, I'm not doing exact mathematical calculation, but what I've done is simply that in a healthy individual, you definitely can be having is a achievement of concentration of the urine. But in diabetes insipidus, if the hormone is not there, then this concentration is definitely not possible. The water will keep on getting lost from the body. So in patients of diabetes insipidus, this concentration will not happen. That's the first point. Point number 2 is Now, what you will do is you can give desmopressin, and if you give desmopressin from outside and the urine becomes concentrated, it means there was a deficiency. On the other hand, in spite of giving desmopressin from outside, if there is no change, that means that the receptors are malfunctioning. That means it is a nephrogenic variety. So point number one is, if you know the interpretation with respect to a healthy individual, you can definitely work up that in diabetes insipidus, this kind of a urine concentration is not possible. And then you can intervene with desmopressin and check out the varieties. And anyway, the values of antidiuretic hormone would also give you a hint. Another test I can do in the patient is a MRI head. This would help me in especially central diabetes insipidus. So I just want to say that the T1 weighted image MRI head in a normal individual, the posterior pituitary will be visible in the form of a hyper intense signal. But in central diabetes insipidus, because the posterior pituitary can be damaged from causes ranging from, let me say, sarcoidosis, or a tumor, or let me say idiopathic, or let me say a neurosurgery that was done, then that hyper intense signal will be lost. I repeat the fact once again. In a normal individual, the posterior pituitary can be visualized as a dot of a hyper intense signal. This is perfectly normal for all of us. But in patients of diabetes insipidus, this signal will definitely be lost. The one that I'm talking about at the moment will be, however, valid for the central variety, not for the nephrogenic variety. Remember, two important reasons for nephrogenic diabetes insipidus, that's going to be lithium and hypercalcemia. Instead of asking you the treatment per se, they love to ask you causes. Now, once we have identified the condition, it will be time for treatment of these patients. So the first treatment that I'm going to do, or the first line drug for treatment of central diabetes insipidus, is anyway straightforward. That is desmopressin. This would be recommended not to be taken in form of nasal spray, but rather in the form of tablets, because nasal spray will act very fast, so it can cause SIADH like manifestations. It can even cause hyponatremia. Remember, this chap was having hypernatremia because water was getting lost from the body. It can cause a reverse manifestation also.
Question 5. An 11-year-old child with a history of streptococcal pharyngitis presents to you with fever and arthralgia. There is no past history of rheumatic heart disease or features of carditis or valvular disease. The child weighs 25 kgs. How often is 600,000 U of benzathine penicillin recommended for prophylaxis of rheumatic heart disease? Your options are, and the correct answer is once in 4 weeks for 5 years or till the age of 21, whichever is longer. Here's the explanation.
And coming to the AHA guidelines for secondary prophylaxis, we shall be in this particular case giving long-acting penicillin, that is shots of benzathine penicillin would be administered to the child. The range at which the injections of benzathine penicillin would be given intramuscularly will range between 3 to 4 weeks, though he says that for high-risk cases, you might be giving penicillin as early as 2 weeks. I repeat the facts once again on the slide. One, I said that though the range is between 2 to 4 weeks, I've written 3 to 4 weeks because that's the conventional norm. But suppose a kid is having MR and AR, and I don't want those valvular lesions to worsen, and I don't want a recurrent sore throat, so I'll tell the mother, come every 2 weeks. There's a possibility the mother may not come every 2 weeks. She may delay it because, as Indian patients do, marriage in the family, festival in the family, I don't have time, something like that. So I want that at least in 1 month period, because the effect of medicine will last for 1 month. They would be, this benzathine penicillin will cause a minimal inhibitory concentration in the blood of the patient that will prevent colonization of the throat by group A streptococcus. So I want the mother to be compliant and regular in her follow-ups, and we should always write this word after test dose whenever we are giving benzathine penicillin. Suppose the child was receiving benzathine penicillin for 1 continuous years, and every time test dose was being given, nothing happened in the kid, and he received penicillin, went back home after observation period, and there were no problems. And maybe after 1 year, your staff nurse was changed, and the new nurse did not read your orders properly, and she gave penicillin to the patient without giving a test dose, thinking that this child, because in the prescription multiple dates will be written, this child has received penicillin for last 1 whole year, and therefore I don't need to give a test dose because nothing has happened. And unfortunately, all hell breaks loose, because the moment she will give it, there is a possibility that the lips of the child will turn blue, and this child can even die. You must always give a test dose before you give penicillin, ideally recommended before every shot of penicillin. Otherwise, anaphylaxis will always be there, or can be there, and you never know when it will occur. Anaphylaxis with penicillin is very unpredictable. The reason for death after anaphylactic shock can be laryngeal edema, And once that develops in the MCQ, laryngospasm will also be there, laryngeal edema will also be there. Histamine is being liberated here, so therefore laryngeal edema will be a profile or manifestation. The lips will turn blue and you cannot even intubate in a patient. Anaphylaxis is mediated by which cell? Then you know from pathology, do not answer eosinophil. Do not answer eosinophil. Anaphylaxis would be mediated by basophils. The cytokine which would be involved in this case is interleukin 4. So a couple of, I would say, pathology based aspects. And for management of anaphylactic shock, what would you do? So you will break open the ampule of adrenaline and you will give it undiluted. The only scenario in emergency medicine where you give undiluted adrenaline is for an anaphylactic shock. Every time else, every time for cardiac arrest or even in patients of pulsus electrical activity or ventricular fibrillation, ventricular tachycardia, wherever I have talked about adrenaline, it has always been diluted. The only scenario where I'm speaking about undiluted adrenaline is right now. You break open the ampule, half of it, 0.5 ml IM adrenaline would be given undiluted to the patient, because we want a rapid onset and you don't want to waste time securing IV access because histamine will cause vasodilation. As far as the durations for which the antibiotics would be required have already been discussed. I have talked about the traditional data, rheumatic heart disease with a valvular region demonstrated clinically or echocardiographically. The injections would be given till 40 years of age, if not agreed, 10 years since the last attack, whichever is longer. This word always has to be remembered, whichever is longer. So I want to increase the duration of secondary prophylaxis. If it's gonna be with carditis, then the injections will be 21 years or up to 10 years, whichever is longer. And without carditis, which has been the standard question, then either till 21 years of age or at least till 5 years. Obviously the first answer would be 21 years. And every time we are giving this injection, I would prefer that test dose would be given. Otherwise, anaphylactic shock can occur.
Question 6. Which of the subsequent is absent in men 2B syndrome? Your options are. And the correct answer is parathyroid adenoma. Here's the explanation.
Primary hyperparathyroidism, let us assume this to be 4 parathyroid glands. We usually tend to have is a adenoma or a tumor in the inferior parathyroid glands, though it can arise in anyone. But this is what the textbook says, that mainly the parathyroid adenoma tends to arise in the inferior parathyroid glands per se. Though you could be having is a parathyroid carcinoma as well, but most of the time it's gonna be an adenoma. And from the histopathology perspective, the main cell which would be causing the problem here would be chief cell. So the first 2 points that I've said is mainly from the location perspective and from the histopathological perspective. And now let's look at what is actually gonna happen to the patient. Once the values of PTH will spike, you will notice that the calcium values will start rising in the patient. Normal calcium values are in the range of 9 to 11 milligram percent. And in these patients, you could be getting is a value which could go up to 15. Why am I worried about a calcium values as high as 15 milligram percent is that there is a possibility of a cardiac arrest. Yes, guys, hypercalcemia that can occur due to any of the conditions that we're going to discuss. Primary hyperparathyroidism is one of them. If it's undetected, calcium value spike, person can die as well. The usual age of presentation in parathyroid adenoma, which is contributing to primary hyperparathyroidism, would be in the 3rd to the 5th decade of life. And let us now look at why this person would come to you. And one broad term that I can describe for this individual who is either having a solitary adenoma. One possibility is one of the parathyroid glands, there is a tumor. Sometimes these patients could be having is an association with multiple endocrine neoplasia. When you listen to the MEN syndrome, there are 4 varieties of it. Then you will notice that parathyroid adenoma will be occupying its position in both multiple endocrine neoplasia type 1 as well as in multiple endocrine neoplasia type 2, but not in MEN 3 / which is formerly called as MEN 2B.
Question 7. What should be the next course of action in managing a patient who has had diabetes mellitus for the last 5 years and is currently experiencing vomiting and abdominal pain? The patient is not adhering to medication and shows signs of dehydration. Diagnostic tests indicate a blood sugar level of 500 mg per deciliter and the presence of ketone bodies. Your options are. And the correct answer is intravenous fluids with regular insulin. Here's the explanation.
You see, they can change the question in the forthcoming sessions as well. So what you need to keep for or watch out for, that if he mentions that the same case of diabetic ketoacidosis has gone into shock, if he talks about circulatory failure and he says, what will you be doing in this patient? Then you will not answer even IV fluid straight away, because in any patient who's gone into a circulatory failure, there is a coma, there is a decreased level of consciousness, the BP is unrecordable. I need to take care of the airway of the patient. I need to put in an NG tube. I'll take care of the breathing part, and then would come a normal saline bolus. So if he's going to talk about per se the fluid management for a child of diabetic ketoacidosis who has gone into circulatory failure, if there is mention of the word coma, if he mentions regarding circulatory failure and pulses not being palpable, I would suggest you to answer this as normal saline bolus. On the other hand, if he talks about minimal dehydration and he says that the patient can take orally, and he says what will you do in the patient, then you can use subcutaneous insulin. Remember, in the question that I shared before you, asked in 3 different exams by 3 different authorities, subcutaneous insulin was in the options. But why was it not selected? One, in an emergency scenario, I need to give intravenous insulin. Second, my patient was having acidosis as well as was having coma. So he was fitting into this particular part of the discussion. Let's just go back to the previous slide. I said the patient is having acidosis. The pH was 7.2. The patient was puking. That implies that he's having moderate dehydration. So what are you going to do in this case? You're going to start normal saline. This normal saline would be 10 to 20 ml per kilogram of body weight initially, and then after 1 hour of this, you can see what I was saying, that the continuous insulin infusion has to be started 1 hour after IV fluids. And when you will give IV fluids to this patient, then obviously the ketonemia part will be taken care of. But there's another problem that also needs to be handled, because the patient has been having continuous vomiting. The total body potassium of these patients is reduced, and therefore to manage this hypokalemia, what we will do for the IV fluid, what I will do to the bottle of normal saline is that we will add potassium chloride as well. How much potassium should be added? That would be 40 millimoles per liter at a concentration of 40 millimoles per liter. So the message is, in a patient of diabetic ketoacidosis, if he talks about circulatory failure, then I'm going to talk about airway, breathing, and then a normal saline bolus. Whereas if he talks about moderate dehydration, I'm going to give normal saline to the patient with potassium chloride, and after 1 hour of the same, insulin drip is to be started. If it talks about minimal dehydration, we'll give, and the patient can tolerate orally, then it's okay. I mean, we can give subcutaneous insulin to the patient as well. We'll talk more in detail regarding this algorithm, but this is an updated data which I would just like to share with you, which is totally in contrast to what was present in the previous editions of the app, whether you take a 4.0, 5.0. I mean, in all of them, we have talked about a bolus, but then this is an update that we need to be taking into consideration.
Question 8. A hypertensive patient who is non-compliant with medication presents to you with sudden onset breathlessness. A chest X-ray was done, which is shown below. How will you manage this patient? And the correct answer is intravenous nitroglycerine. Here's the explanation.
One is a person who's having volume overloading, and this is contributing to acute pulmonary edema. The person is having extreme amount of breathlessness. The SpO2 on admission in room air is, let me say, only 80%. So in these circumstances, the first and the foremost thing that you need to do is provide oxygen to the patient. And to give this oxygen, well, the best method would be not to use a routine nasal cannula or a routine mask, because gas can easily diffuse out. So it always makes sense that in patients who are having acute pulmonary edema, the person should be made to sit up in the hospital bed, and you can use a tight fitting face mask that is non-invasive ventilation. This will definitely improve the oxygen saturation of the patient. Apart from oxygen, we need to give Lasix to the patient, that is a diuretic. I want to reduce the pulmonary edema component by using loop diuretics in this case, though I know that they can be concomitant hypokalemia if I use large dosages of furosemide, but I'm ready to actually, let me say, bite the bullet, mainly because at the moment the patient is in bad state. Well, the mnemonic that you can use, in fact, this is the only mnemonic that Harrison has used, as LMNOP. I mean, Harrison gives you a lot of text, but he's given you a mnemonic that is LMNOP. So Lasix, morphine, nitrates, oxygen, and positioning. Well, as far as morphine is concerned, I want to highlight why are we giving morphine for a person of pulmonary edema, because if you read pharmacology, it says morphine causes shunting of blood from pulmonary to systemic circuit. Please appreciate, here I'm not giving morphine for relief of any kind of chest pain, and I have a lot of agents apart from morphine to relieve chest pain. I am giving morphine to this particular patient. Why? Because I simply want to reduce the pulmonary edema component. If you read pharma, morphine is obviously an effective analgesic, but it also reduces pulmonary edema component by shunting of blood from the pulmonary circuit to the systemic circuit. Then I will be also ensuring proper positioning of the patient. The hospital bed can be definitely adjusted so that the legs of the patient will be relatively lower and the head would be relatively higher. And over and above this, I also need to give nitrates to the patient. Now listen to this part very carefully. The reason why you're giving nitroglycerin in a drip format to your patient is because it will reduce the preload, afterload, dilate the coronary artery. So it's a win-win situation because the heart needs to be rather given a little bit of rest. What I mean by given a little bit of rest is that if you reduce the afterload, if you reduce the preload, then the stress on the heart, the workload on the heart is dramatically reduced, and therefore it will be able to function relatively better. The pumping action of the heart will remain the same. But if you reduce the preload and the afterload, then it will be better at clearing the pulmonary edema component developing in a patient. And lots of time in MCQs, instead of nitroglycerin, they might actually mention a new drug by the name of nesiritide. It is not that new, but I would say just in comparison sake, he can talk about the traditional nitroglycerin drip, or he can talk about nesiritide infusion being given in the patient. Now the advantage of nesiritide is, what is it gonna do? So this will behave like BNP in the body. Earlier I was teaching you in ARNI, I was inhibiting the breakdown of BNP. So BNP will work for longer duration. In this case, I can say this is purely a BNP analog, and because it will behave like BNP, it will cause natriuresis, and that is the advantage of this drug, because you want to kick out the extra salt and water, and all patients of congestive heart failure are anyway having secondary hyperaldosteronism. Therefore, they are already having more salt, more water in the body. If I kick out the salt and water, it will definitely reduce the problems for this patient, in a sense that the volume overloaded state of the person will definitely become lesser.
Question 9. What acid-base imbalance is most likely to be observed in a middle-aged man with chronic renal failure on dialysis who experiences sudden collapse in the emergency department and exhibits labored breathing, as evidenced by tall, tented T waves on the ECG? Your options are, and the correct answer is pH 7.14, PCO2 to 20 mm of mercury, HCO3 to 5 milliequivalents per liter. Here's the explanation.
Now, when it comes to RTA1, what's happening is that in the distal convoluted tubule, we have a couple of cells. One of them is called as alpha intercalcated cells. And the main function of this alpha intercalcated cells would be that they will help in potassium balance, or they will help in potassium excretion from the body. The importance of knowing this would be that suppose if there is going to be a damage to the alpha intercalcated cells, then this hydrogen ion excretion would not take place, and therefore you would have a buildup of hydrogen ions in the body, and that will explain the metabolic acidosis component. You see, one of the basic functions of the kidney is to maintain the acid-base balance in the body. So we also have what is called as beta intercalcated cells, and these chaps are responsible for bicarbonate excretion. So you can see that the kidney is able to maintain a fine balance between the base and the acid component, and thereby helps in keeping a stable pH of 7.35 to 7.45. Now, what I'm saying is that in RTA1, what fundamentally happens is that these alpha intercalcated cells would not be functioning properly, as a result of which the first manifestation that develops in these patients would be written in MCQs. Obviously, we are talking about metabolic acidosis in the patient, but how would he write it in a multiple choice question is what we need to learn. So he will say impaired hydrogen excretion, primarily because the alpha intercalcated cells are not working, and therefore metabolic acidosis will ensue. Now, there's a separate function of the kidney as well. Like I told you that one of the functions of the kidney is maintenance of the acid-base balance. The second important function of the kidney, over and above the acid-base balance maintenance, is that it is also responsible for maintenance of electroneutrality. By electroneutrality, I mean the positive charges and the negative charges will have a balance. The positive and negative will cancel each other out. So what's happening here is that hydrogen ions, which are positive, are not getting excreted. If positive charges will not be excreted, then the kidney will respond here by also causing a impairment. This point number 2 that I'm saying is the response of the kidney, that it will respond by impairing chloride excretion. Now, if you look at it from the mathematical perspective, I can say positive charge was not getting excreted. So the kidney decided that, okay, I will not allow the negative charges also to be excreted. And now the positive and negative charges can balance each other. That's what I mean by the word electroneutrality. But the importance of knowing this fact is that because there is an impaired chloride excretion in the patient, that is why whenever you read about renal tubular acidosis topic, the textbook will always say this term, hyperchloremic metabolic acidosis. I'll explain this point once again. Metabolic acidosis is easy to understand. Hydrogen ions are not getting excreted from the body. But what I'm trying to now say is that to counterbalance, the words are to counterbalance the positive charges in the body, the negative charges, excretion will also be impaired. The kidney will, this is point number 2, is the response of the kidney to impairment of inability of the body to get rid of the positive charges. So the negative charges rise, and therefore you have is a hyperchloremic metabolic acidosis developing in the patient.
Question 10. In a male patient who is a chronic alcoholic, he has come in with abdominal distension, reduced urine output, and swelling in the feet, pedal edema. Upon examination, his serum creatinine level was found to be 1.6 mg per deciliter. What would be the appropriate course of action in managing this patient? Your options are. And the correct answer is octreotide plus albumin. Here's the explanation.
However, that will take some time. So let's look at what is the treatment to be done for these patients. The first and the foremost drug that I can use in this patient over and above albumin will be octreotide, or I can be using midodrine as well. Now, what is the role of these octreotide or midodrine molecules per se? Because they are after all vasoconstrictors, and the query from most of the doctors is that, sir, on one hand you are saying this disease is having a renal vasoconstriction and you're giving vasoconstrictors. Well, I want to tell you that these are vasoconstrictors that will be mainly acting on the splanchnic blood vessels. When they ask about the action of octreotide, it is mainly going to be on the splanchnic arteries, and as a result of it, if you constrict the splanchnic arteries, then I can say the venous flow, the portal venous flow will definitely reduce, and if I reduce the magnitude of portal hypertension, then the severity of all these manifestations will also reduce. I want to highlight this fact. What this drug is doing by its vasoconstrictor action is, one, it will act on splanchnic arteries as well as splanchnic veins. If you constrict arteries, the venous blood flow will anyway be reduced and even the veins will be constricted. So what you are neutralizing in this case is the splanchnic vasodilation. By use of octreotide and midodrine, I am not neutralizing the renal vasoconstriction, because that's a protective reflex. Every time kidney suffers, it undergoes a renal vasoconstriction. So I'm not trying to neutralize what the kidney is doing routinely. What I'm trying to neutralize is point number 2 in the pathology, that is splanchnic vasodilation, which was occurring in this patient and was contributing to less blood supply to the kidney. This is the one that is primarily being neutralized in this case. And yes, subsequently this patient will be requiring a orthoptic liver transplantation.
Question 11. A 20-year-old woman presents with breathlessness and chest pain. She is a known case of mitral stenosis. Her pulses are regularly irregular. No thrombus is seen on echocardiography. What is the best agent to prevent future thrombotic events? Your options are. And the correct answer is oral warfarin. Here's the explanation.
If he talks about the drugs that you would be prescribing to these patients, one of the drugs that you will be prescribing is warfarin. Why? Because there is increased risk of cerebral embolism in the patient. These patients can be having a mural thrombus because of the fibrosis in the heart. There could be clotting cycle activation, and therefore you could be having clots in the left ventricle or in the left atria, and therefore these clots could be going into the brain, and I want to reduce the chances of cerebral embolism in the patient.
Question 12. A woman presents with numbness of her fingertips. On examination, the skin over her face appears tightened. The anti-nuclear antibody, ANA, is found to be positive and immunofluorescence shows the nucleolar pattern. What is the likely diagnosis? Your options are. And the correct answer is systemic sclerosis, scleroderma. Here's the explanation.
Skin tightening and skin thickening. In fact, because of this skin tightening and skin thickening, one of the early manifestations that would develop in the case would be loss of transverse creases. Like we all have these creases present on our interphalangeal joints. And if you look at the first image where I'm putting the white arrow, you will notice that in this person, there is a complete loss of the transverse skin creases. And then the skin thickening and the skin tightening will continue. It will start from distal, go to proximal, then will involve even the face of this patient, even the trunk would be involved. And in fact, in the later part of the stages, the extensive amount of skin thickening that is present can be responsible for contractures, which would be flexion contractures in the hand. And therefore, if you look at the second image, you can notice that claw-like appearance of the hand. And the term that's used to describe this claw-like presentation would be referred as sclerodactyly. So I can say that at this moment, I've covered 2 features of the disease where we're keeping the Y alphabet silent. And then the next thing that has to be remembered is telangiectasias. Well, where would you be checking for these telangiectasias? They would be present on the cheeks, on the lips of these patients. I'll be showing you an image of these telangiectasias as well. But at the moment, I would like you to remember that these telangiectasias imply vasculopathy, microangiopathy, damage to small blood vessels in these patients. And in fact, the number of telangiectasias has been found, or the severity of telangiectasia is directly proportional to the severity of pulmonary artery hypertension as well. Then even the GI tract is involved in this condition, fibrosis synchronously affecting multiple body organs. I mean, that's the easiest way I can make you remember this condition. The extensive fibrosis in all organs occurring at the moment is in the intestine, and that would explain the manifestations of esophageal dysmotility. There would be decreased tone of the lower esophageal sphincter. This will also cause GERD and reflux esophagitis. And because the gut motility in this condition would be hampered, it would be slower because of the fibrosis occurring in the gut. Therefore, another manifestation, that is the alphabet M, would come up, would be malabsorption syndrome. And therefore, weight loss can also be explained in these patients. Diarrhea can be explained in these patients. Then the next reason that I'm writing, that is alphabet I in systemic, is one of the main reasons why these patients would be dying. And this interstitial lung disease subsequently responsible for development of pulmonary artery hypertension. So in most of the cases, it is a combination of interstitial lung disease and pulmonary artery hypertension which results in death in these patients. Alphabet C would stand for calcinosis, that would be calcium deposits in the skin, and this calcinosis cutis is occurring in a setting of normal calcium and phosphate levels. Well, then what is the calcinosis composition here? It would be answered by you as calcium hydroxyapatite. I'm going to write calcium hydroxyapatite in the later part of the discussion, but at the moment just sensitizing you to the fact that unlike in patients who are having CKD or patients who are having hyperphosphatemia, where calcium and phosphate will chelate, and then you could be having calcium deposits in the skin as well. But at this moment, it is calcium hydroxyapatite for the calcinosis part. Then alphabet I would represent that there would be immunological abnormalities seen. And one of the most important immunological abnormality, the villain antibody behind development of this autoimmune condition, would be called as anti-topoisomerase antibody. In fact, in the later part of this discussion, I'm going to talk about a total of 9 antibodies seen in systemic sclerosis. But one of the key words in the question that would be present would be one, skin thickening sclerodactyly, another one would be topoisomerase antibody described. And the amount of fibrosis in this condition can be occurring, the amount of fibrosis and the extent of fibrosis can be so extensive that it could be even involving the tendons. And that is why we can be hearing, we are having audible tendon friction rubs in these patients. Traditionally, we read pleural rub, we read about pericardial friction rub, but today I'm teaching you about tendon friction rub. That's because of the contracture, that's because of the fibrosis, that's because of the calcification that would be occurring in the tendons. And then alphabet R would be standing for whenever this patient, who's mostly going to be a female patient, as all rheumatic disorders are more common in women. So every time she's going to be putting her hands in cold water, there's going to be change in the appearance of the tip of the finger. First, there is going to be an exaggerated vasoconstriction, so the tip of the finger will become wide. Then the stasis of blood here and the ischemia of the tissues will cause the tip of the finger to be appearing blue, that is cyanosis, and subsequently there would be redness appearing, and this would be associated with pain and discomfort as well. So Raynaud's phenomenon will also be encountered in these patients, and that's again a very good point. Raynaud's phenomenon, in fact, the pointers that I'm saying is topoisomerase antibody, though all of these features have to be remembered by you, but then skin thickening, Raynaud's phenomenon, topoisomerase antibody, even tendon friction rubs are like very characteristic manifestations seen in this case. Patients would be having extensive tendon friction rubs, interstitial lung disease, scleroderma, renal crisis, and in an integrated kind of a question, he might describe immunofluorescence study as well. Written on this immunofluorescence slide will also be the word HEP2, which basically means human epithelial cells, which are derived from a patient with laryngeal cancer. They are put on a slide, and then you incubate the serum of this person with the HEP2 cells. And in case there is going to be antibodies against the various components like topoisomerase, centromere, or against any nucleoli, then this would light up because immunofluorescent probes would be used and the whole sample would light up, and therefore you can see a very discrete pattern, but it would be so discrete. The fine green dots will be so closely linked to each other that the whole thing will appear homogeneous. And therefore, in case they give you an image-based question where you can see the first image, anti-topoisomerase antibody, it would be a discrete homogeneous pattern described.
Question 13. For a patient with a serum bilirubin level of 2.5 mg per deciliter, serum albumin level of 3 grams per deciliter, prothrombin time of 5 seconds, INR equals 2, encephalopathy of grade 1, and mild ascites, what would be the child Turcot Pugh class? Your options are. And the correct answer is class C. Here's the explanation.
PELD score, because they would definitely like to incorporate the pediatric component as well. So in the pediatric component of the PELD score, again, bilirubin and INR would still be sharing the stage. I mean, these guys are anyway gonna be incorporated in any liver staging. But then we have a couple of parameters which are over and above this, which are to be remembered. So two A's will come in, that is albumin and age, and then would be growth failure. Most of the time in the exam, with respect to the liver topic, they love to ask about the various type of scores. Like in alcoholic hepatitis, I talked about discriminant scores / discriminant function. In fact, the person who gave that discriminant score, his name was Madry's, so they used the word Madry's score in the MCQ as well. I've given the mathematical values in alcoholic hepatitis. You can refer to that lecture. But the point is, Madry's discriminant score, discriminant function, is for severity of alcoholic hepatitis. MELD score, MELD NA, and PELD score, they are used to determine percentage chances of mortality in a patient, and obviously enlisting a patient for orthoptic liver transplantation. And therefore, we will be able to identify cirrhosis in our patient. If I go back by a couple of years, what I used to read was the standard child pug score, where the components were bilirubin and INR, obviously enjoying their, I would say, important status. But then we were having 3 A's coming up, which are just being mentioned here for practice sake. One would be the values of albumin, and as albumin will progressively reduce, the severity of ascites in a patient will definitely keep on increasing. Initially, it will be medically responsive, then it will become medically refractory as well. And as the liver will get decompensated, the blood ammonia levels will start rising. So there would be a visible flapping tremor or asterixis occurring in the patient. And you will notice that all of these parameters will keep on getting deranged or increased with time, except for the value of albumin, which is one of the important parameters that we anyway use for chronic liver disease. At this juncture, I also want to say that the score of these patients can vary between 5 to 15. And in the exam, what they can do is just introduce some statistical data. So when it comes to category A patient, the score will be between 5 to 6, and we'll say this person is having compensated cirrhosis. When would we say that the person is going into a decompensated state? That would be the category or categorization class B coming up. When I say class B, then the scores would be anywhere in the range between 7 to 9. And if the scores go much higher than that, that is more than 10, then definitely the more complications will occur.
Question 14. Which of the following statements accurately describes the initial management of a 60-year-old male patient, previously diagnosed with COPD, who is currently experiencing an acute exacerbation and has been admitted to the ICU? Your options are. And the correct answer is non-invasive PPV should be given. Here's the explanation.
Whenever there is hypoxia, our body will tend to respond by causing a bradycardia. There would be then a breathing effort, a deep sighing and a breathing effort on our part, so that we can increase the respiratory drive and normalize the oxygen saturation in the body. These people either have a poor or absent respiratory response to hypoxia and hypocapnia, which basically means the fact that the sensors in their body that respond to hypoxia and hypercapnia, like in the carotid body, we have sensors for checking for the oxygen saturation in the blood. Those sensors are not working very properly. So for management of these patients, we will have to use a non-invasive positive pressure, intermittent positive pressure ventilation, or we might have to use mechanical ventilation, or the latest treatment for this condition, and that is why I've gone through it, because that's the MCQ. Phrenic nerve pacing or diaphragmatic pacing is done for. Then phrenic nerve and diaphragmatic pacing is not done for OSA. It is rather done for central hypoventilation, where the sensors picking up hypoxia are defective. So you need to make this person breathe on a continuous basis, irrespective of the fact that whatever is the oxygen saturation in the body. So in these particular patients, response to hypoxia becomes lesser. Like if they go to a high altitude, when you go to high altitude, your body will try to respond by helping you breathe faster. In this case, the response is lacking. So that's why I said phrenic nerve pacing is not for OSA. It is for central hypoventilation syndrome. I also want you to be clear that I have just taught you OSA, obstructive sleep apnea hypopnea syndrome. Do not mix it with what is called as obesity hypoventilation syndrome. Now, what do you mean by the word obesity hypoventilation syndrome? Is simply the fact that this particular individual, he may not be having that increased daytime sleepiness, or he may not be having this repeated nocturnal awakenings present. All this condition says is that the person is obese, the body mass index is more than 30, and in these patients the PCO2 is usually more than 45 millimeter of mercury, which explains the carbon dioxide narcosis that could be occurring in this patient. So these patients mainly have a chronic daytime hypoventilation. In these particular patients, there may or may not be presence of apneic episodes. So obesity hypoventilation syndrome, as the name suggests, simply tells you that there is a elevated carbon dioxide levels in the body because they breathe lesser as compared to normal people, but the symptoms of increased daytime sleepiness, apneic episodes, hypopnea episodes may not be present in this particular individual.
Question 15. In which of the following conditions is water hammer pulse observed? Your options are, and the correct answer is aortic regurgitation. Here's the explanation.
Only 2 ml, 3 ml, 4 ml, 5 ml, little amount of blood is leaking back into the heart due to any of the reasons that we have discussed. If the amount of blood that will come back here will be relatively lesser, it is going to contribute to stretching of the wall of the left ventricle. The stretching of the wall of the left ventricle will then cause an increase in the force of contraction of the left ventricle. Guys, what I'm teaching you here is a law of physiology. In the first diagram that I drew before you, there was no physiology that was operating because everything happened very fast. But if less amount of blood will leak back in, Frank-Starling law can definitely come into the picture. And you very well know meaning of the word Frank-Starling law is that if you stretch the myocardium, it responds by contracting more forcefully. So whatever extra volume of blood came in, it could be 1 ml, it could be 2, it could be 5 ml. But because it will add power, therefore when you're going to check out the pulse of this patient, you will notice a fast rising pulse. In aortic stenosis, I have described a slow rising pulse. Pulsus parvus attardus, I have described the word anacrotic pulse, but here I am saying fast rise thanks to the increased power which is coming in with this little amount of blood that is leaking back into the heart. But after that, you will notice a fast fall also. Why? Because there is incompetence of the valve. So you are having two features, the fast rise due to Frank-Starling law, fast fall due to incompetence. I repeat again, fast rise due to Frank-Starling law, fast fall because of the incompetence of the valve, and therefore you always get this characteristic feature that is Corrigan's pulse, or is also called as water hammer pulse, or is also called as a collapsing pulse. This is a feature that you encounter in the chronic format of aortic regurgitation.
Question 16. Which of the following is true about polyarteritis nodosa? Your options are, and the correct answer is 30% is associated with hepatitis B. Here's the explanation.
Polyarteritis nodosa, pulmonary artery is not involved. Just remember from the PAN word, N basically stands for not involved. So hemoptysis will not be encountered ever in polyarteritis nodosa. The most common body organ involved in polyarteritis nodosa happens to be the kidney. Because the kidney blood vessels would be involved in this case, there can definitely be hematuria. But this hematuria is not occurring because of damage to the glomerulus. It is rather occurring due to damage to the blood vessels. So there are two things which are not seen in this condition. I'm just putting a crosshair to say glomerulonephritis is not seen with polyarteritis nodosa. Pulmonary artery involvement is not seen with respect to polyarteritis nodosa. So the crosshair means involvement is not present. The disease can cause necrotizing vasculitis that can affect the blood vessels supplying the tip of the fingers. So you will read about digital ulcers as well as digital gangrene. You don't read about gangrene in Wegener's granulomatosis, but PAN, it's peripheral blood vessels, the smaller blood vessels that are getting involved. You know that in PAN it is small to medium blood vessels that are involved, so that's why digital blood vessel involvement and manifestations are described. You will also read about hypertension in this condition because the branches of the renal artery, I'm not saying the main renal artery, it is the branches of renal artery that can be affected. So hypertension can be present. In fact, combination of hypertension and gangrene is something that you don't see anywhere else but in polyarteritis nodosa. So question can be a long one, but combination of these two features would help you in the diagnosis component. Then coronary artery vasculitis can occur, so MI will occur. there's a possibility that vasculitis of brain blood vessels will occur, so stroke features can occur in the patient. And if it is skin blood vessels getting involved, then you might be having a fishnet appearance of blood vessels, that is livido reticularis. Fishnet appearance on skin biopsy immunofluorescence is what you read with pemphigus vulgaris, but here I'm talking about simply not a biopsy. I'm just saying the physical appearance of the skin to naked eye. I'm not talking about any immunofluorescence study. To the naked eye, there would be a fishnet appearance of the blood vessels running in all directions, which we call as livido reticularis. The antibody that can be present in this case is P-ANCA. Though P-ANCA, where is it strongly positive? I'll mention on the subsequent slide. P-ANCA positivity can be present. I'm saying can be present. And he has also asked in the exam that this alphabet P, that's for the perinuclear antigen, he's saying that this is directed against which antigen. So your answer would be myeloperoxidase. Two pathology domains here, proteinase 3 and then myeloperoxidase are the targets which are being affected in this particular case.
Question 17. Which statement is accurate regarding paroxysmal nocturnal hemoglobinuria, PNH? Your options are, and the correct answer is deficiency of CD55 and CD59. Here's the explanation.
Paroxysmal nocturnal hemoglobinuria, there is a problem with CD59 which is on the platelets. It prevents intrinsic platelet activation. I mean, in our body platelets get activated when there is a injury, but in this patient the platelets tend to express more of thromboxane A2 in the absence of CD59, and therefore there can be a platelet aggregation occurring even in the absence of trauma. As a result of it, the thrombus formation chances will increase. You see, CD55 is absent on the RBC, so they become susceptible to complement-mediated destruction. So that's why we read about anemia, and that anemia can be fairly extensive. So hemoglobin can come in the urine, that would be hemoglobinuria. But on the other hand, if it is CD59 and both aspects are present in PNH, I mean, PNH is not a disease of the quantity of RBC, WBC platelet, it is a disease of quality. RBCs are of poor quality. What I mean by poor quality, CD55 is not there, so complement will destroy it. CD59 is absent, so platelets are getting activated even without an extrinsic stimulus, that is in the form of a trauma, and therefore the clumping of the platelets will contribute to a hypercoagulable state. So in the question, most of the time, initially he is going to describe a patient who's suffering from a hematological disorder, and then subsequently there would be a triad of tender hepatomegaly plus ascites. That's one of the standard features, ascites. Why? Because there will be portal hypertension and there would be right upper quadrant pain developing in the patient. I'll describe the triad subsequently. I've already said it verbally. Features would be presence of right upper quadrant pain plus ascites plus a hepatomegaly.
Question 18. Except for which of the following, all the mentioned characteristics are associated with Crohn's disease? Your options are, and the correct answer is lead pipe appearance. Here's the explanation.
If I want to differentiate between ulcerative colitis and Crohn's disease, I'll not go by the area involved, because ileum can be involved even in this patient of ulcerative colitis, backwash ileitis, and in Crohn's disease also. One term that will pathologically differentiate between the two will not be these terms like crypt abscess and pseudopolyps, though they ask you that in pathology. So please follow whatever the pathologist is saying for, what is the single best answer for crypt abscess. From a clinician's domain, guys, the main differentiation factor from the pathological perspective is presence or absence of non-caseating granulomas. Your caseating granulomas is TB, that's okay. Non-caseating granulomas are found in Crohn's disease. So in Crohn's, in pathology, you will read the term granulomatous colitis. When it comes to Crohn's, I'll jot it down. Granulomatous colitis. Ulcerative colitis, in contrast, will not have any non-caseating granuloma. So it would be called as a non-granulomatous colitis occurring in a patient. So one of the important histopathological differentiating feature between the two would be presence or absence of granulomas, and not with respect to, pseudopolyps or crypt abscess, because they may be seen even with patients of Crohn's disease. But what is, a 100% valid fact is that a full thickness involvement encroaching up to the serosa, if you are having a serosal involvement occurring in the gut, that is Crohn's. While in ulcerative colitis, there would always be a partial thickness involvement. The whole of the colon can be involved right from the starting to the end, and there might be a retrograde extension of this inflammation to the ileum of the patient, which is called as backwash ileitis. I'll compare this now with pathological features encountered in patients of Crohn's disease. Now, the earliest feature that we encounter in patients of Crohn's disease would be development of aphthous ulceration, and you will also notice that Once these aphthous ulcers are present, in between some normal areas can also be, or uninvolved mucosa could be present, which is what we call as skip lesions. It is the whole of the intestine which is involved in these patients. But if he says that overall, what is the most common site involved in patients of Crohn's disease, then your answer would be ileum. This condition will involve the entire gut. I mean, right from the mouth, you could be having even in fact, I mean, though the entire gut is involved, I said right from the mouth to the anal canal, you could even be having a hepatobiliary involvement in patients who are having Crohn's disease. You could be having a development of Crohn's disease of the ampulla vater, or you could be having damage to the pancreas resulting in a pancreatic fistula in a patient as well. He will also ask you which part of the intestine is spared when it comes to Crohn's disease. Then the sparing will occur of the rectum. And if you're listening to me carefully, I had told you that rectum happens to be the most common site of the gut inflammation proctitis with respect to ulcerative colitis. One of the highlight of this condition would be, however, development of fistulas. The question will mainly describe very severe perianal disease occurring in this patient, or he might say perianal sepsis developing in a patient. So let's look at what I mean by the word perianal disease or perianal sepsis occurring in these patients. The term that I'm writing at the moment, you will not encounter this terminology with respect to ulcerative colitis. We do not get a fistula formation with ulcerative colitis. Fistula formation is seen with Crohn's disease. One of the hallmark feature that we see with Crohn's, not seen with ulcerative colitis, is going to be a fistula formation. So he's going to talk about a perirectal fistula. Apart from this perirectal fistula, there could even be, because he's having constipation, there could be a fissure. Once there is a fissure occurring in a person, it will result in worsening of constipation because fissure will cause pain. So there would be spasm in the gut of the patient. Along with this fissure and adjoining area can get infected. So this person might be having anal abscess. He might even require a drainage for management of this anal abscess. And subsequently, the sequelae would be anal stenosis, that when you will do a digital rectal examination in a patient of Crohn's disease, you will have a anus which is tender to touch. You see, normally if per rectal examination is being done in a patient, when you touch the anus of the patient, it will make the person feel uncomfortable and it will cause a spasm of the sphincter, which is normal for normal person or for any person. But in this patient, along with anal stenosis, tenderness over the anus can be seen, even tenderness over the colon can be seen in these patients. And anyway, the subsequent statement that I say is relatively, you are able to much more relate to this, because every time there is damage in the gut with aphthous ulceration, there will also be development of submucosal fibrosis. So you will have normal area, abnormal area interspersed, and at the same time submucosal fibrosis occurring wherever there is a damage present. So the appearance of the mucosa in this condition is called as cobblestone mucosa. This cobblestone mucosa can be demonstrated both radiologically as well as on endoscopy, and even on barium wheel follow through, this finding can be demonstrated. Pseudopolyps as such, I mean, pseudopolyps are more in favor of diagnosis of ulcerative colitis. That is okay, but because this is a spectrum presentation, I have to write this fact that pseudopolyps may be encountered even in patients who are having Crohn's disease. So do not try to differentiate between the two on the basis of pseudopolyps. Rather, the main aspect would be that in Crohn's disease, as I told you already, there would be presence of non-caseating granulomas, which is why the textbook will refer to this as an example of granulomatous colitis.
Question 19. What is the most frequently observed form of Guillain-Barre syndrome among the options provided? Your options are, and the correct answer is acute inflammatory demyelinating polyneuropathy, AIDP. Here's the explanation.
For the various subtypes of GBS that I've been talking about, like the commonest variety that we encounter is called as AIDP. Acute inflammatory demyelinating polyneuropathy. The highlight of this condition is that there is going to be anti-GM1 antibody that will cause immunological response, a complement mediated damage, and you would be having motor features, sensory features, autonomic involvement as well. A lot of patients with GBS are admitted because they might be having postural hypertension, or they might be having wide fluctuations of BP, because thoracic nerves which are coming out of the spinal cord will also be denervated. As a result of it, even autonomic involvement can be present. So acute inflammatory demyelinating polyneuropathy as a disease per se can be having motor involvement, it could be having a sensory involvement, even autonomic involvement can be present.
Question 20. In a patient presenting with a seizure, when examining their urine osmolality increase and plasma osmolality decrease, what electrolyte abnormality can be anticipated? Your options are, And the correct answer is hyponatremia. Here's the explanation.
In SIADH, because there is gain of water in the body, therefore the plasma will definitely become dilute, but the urine will become concentrated, arrows going in opposite direction. Whereas in diabetes insipidus, if I lose water from the body, then urine will be dilute and plasma will be concentrated. So the first thing that you can deduce right away is that the arrows will obviously go in opposite direction, but you need to figure it out that in diabetes insipidus, loss of water, so urine is dilute. In SIADH, it is opposite. Now let's look at sodium concentration. In SIADH, because there is gain of water, so there will definitely be a hyponatremia present. Arrow is again going down. Whereas in diabetes insipidus, because you are losing water, I said the word relative hypernatremia. Guys, I want you to have the capability to work it out fast under 1 minute, because this is not gonna be like, a separate MCQ. These are two options of a single MCQ, and he's gonna confuse with you with increase decrease.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.